I think we shall go on to our next speaker, Dr. Divya. Dr. Divya, you could share your video. Another very dynamic young surgeon, medical consultant of cornea and refractive services from Arvind Eye Care Systems, Chennai. And she is going to show us her learning tip. On to you, Dr. Divya. Can you share your screen? Yeah.
Is it visible?
Yes.
So I'm going to present a case of zonular dialysis, managing a case of zonular dialysis and phacoemulsification. So here I make a 2.2 mm incision and I initiate capsular rexus under viscoelastic. So as I do the rexus, I notice that there is some kind of phacodonosis that I note. I'm not too comfortable completing my rexus, but I somehow managed to complete it. And I do a very gentle hydrodissection. I do not want to force too much of stress on the zonule. So it's a very gentle hydrodissection that I do.
Okay.
And using the...
Can everybody be on mute? Yes.
So I use the Kruglen's hook to confirm the presence of zonular dialysis. I go around lifting the iris to check for the zonular dialysis and the area where this has happened. So I try to rotate the nucleus, and as you see, there is zonular dialysis at the area of the side port. So then I go ahead and do my phacoemulsification. I clear off all the cortex, the loose cortex that's there. I try to chop, and as you can see, I'm unable to rotate the nucleus as it is supposed to. So again, I inject viscoelastic, and then I put capsule hooks. I use capsule hooks to hold the bag in place. It's about 2.5 to 3 clock hours zonular dialysis. So I tighten the hooks, and then I proceed with phacoemulsification. It's not a very hard cataract, fortunately. It's about grade 2 to 3, probably early 3. I complete my, I try to complete my phacoemulsification, and then I realize that there's a blob of vitreous that comes out through the side port. And, but I still continue with the surgery. During further zonular dialysis extension, what I do is I insert a capsule tension ring. I use the Sinski hook to guide the capsule tension ring into the bag. You can still see that the vitreous is there at the side port. I use the eyelet of the capsular tension ring and guide it into the bag. I complete my phacoemulsification. So I've lowered my parameters. Vacuum is about 400 and aspiration flow rate of about 30. I complete phacoemulsification. It's not too hard, so I was able to finish it off easily and not creating more stress on the zonules. So I maintain the phacoemulsification at the pupillary plane. Now I remove the iris hooks, the capsule hooks. I use a Simcoe cannula for more controlled removal of cortex. So I'm able to control the amount of fluid that gets into the eye. So with minimal irrigation, I try to remove all the cortex. And I also like to do a hydrodissection to loosen up the cortex. So I think this is one thing that I follow to just free up the cortex, and then it's easier to remove it. Then I use triamcinolone to make sure that I strain the vitreous to do a good vitrectomy. With the pre-existing side port, I go ahead and do a thorough vitrectomy. You can see vitreous strands coming out through the side port. Good vitrectomy is done, and ensuring that the port is facing upwards and not towards the vitreous. So after a thorough vitrectomy through the side port, I was not able to access completely, so then I had to go through the main port. I inject a 3-piece lens. I've oriented the haptic in such a way that one of the haptic is at the zone of the dialysis. I hydrate the ports well and complete the case. So retrospectively, there are two things that I could have done. I could have removed the hooks after placing the CTR, and I could have also done a vitrectomy before completing phacoemulsification.
Thank you very much, Dr. Divya. I think it's a pretty textbook picture of the steps in which you did when you suspected dialysis. You used capsule hooks. Like iris hooks would not have helped here. Capsule hooks definitely gives a more equatorial support. And then again, when there's a thought of vitreous coming in, you have put in a CTR, and then you have done a slow motion phaco. You've used tricot. You've done it all. My question to Dr. Rohit or Dr. Saurabh or Dr. Madhukar, any one of you could tell, would you have, see, she even had a centered rhexis at the end of it. So it wasn't, it seemed as if the CTR had done its job. Would any of you want to add a CTS in this particular case, is my thought.
Well, if the basic rule is if it is less than 90 degrees,
yeah,
then you need not add a CTS for that matter.
Yeah.
And if it was decentered, and if it, in this situation, I would not have.
Yes.
Because it was less than 90 degrees as it appeared. But
and
then
she had a centered rhexis at the end of it also. So there was,
and the alignment of the IOL intraocular lens was also aptly done. Yeah, a few points, you know, like triamcinolone could have been used earlier. The vitreous could have been cleared earlier. You know, and then using the hook to disengage the vitreous from the, you know, from the side port is something which should not be done, because that puts a lot of traction on the vitreous base. So that should be avoided by all means. A cutter should have been used, I personally feel, because, you know, this is what when I was in medical college, we learned that we use, you know, these hooks to, you know, clear the vitreous from the incision sites. But that is something which Steve Charles has very strongly recommended. That puts a lot of stress, and this should be avoided by all means. You know, and at the end of the day, the results were good. So that we would like to congratulate her for that matter.
Yes.
Little thing which I would do differently is put the CTR after removal of the cortex. So I preferably use MST capsular hooks, which are double flanged, and they give much better support than the single flange capsular hooks. So you can just complete the phaco just like routine, because it gives very strong support, and the cortex removal also, and then put the CTR. So I think you did it wonderfully, but many times we get stuck with the cortex removal because it is under the CTR and you spend a lot of time there. So maybe putting it after removal of the cortex will be easier to do.
Yes. Yes. Dr. Satyajit, you want to add anything to it?
You know, as far as the Dr. Saurabh, as far as the cortex, sorry, I thought Dr. Satyajit was not there. Cortex, you know, the basic plan is that Dr. Saurabh, if we can discuss about this, the CTR, you know, should not be delayed much. It should be put as early as it could be, but not later than what it is required to be. You know, as far as removing the cortex is concerned, that should not be, I personally believe, it's open for discussion. That should not be a factor for you to delay implanting a CTR. Because if CTR is there, you can do tangential stripping to remove the cortex, or you can do reverse stripping by removing the posterior lamella and just removing it. Because at times, if we delay the CTR implant, because I have seen Dr. Chitra is a great believer that the moment she finds that the cataract is subluxated, after capsulorhexis, she puts on the CTR at that moment only. Am I right, Doctor?
Yes, I do believe a CTR should be placed, especially in this case when vitreous is also presenting. Leaving it off, and then you end up with a larger area, and then you need to use a extra supportive mechanism. This particular case, it seemed definitely mandated a placement of CTR as and when it was placed. Yes, I also do believe that. Thanks a lot, Dr. Divya, for a wonderful case and more learning.